Welcome, everyone. It looks like we're at the top of the hour, and we're here to present the EMTALA Made Simple webinar for you, a clinical quality insights presentation from Chartis Clinical Quality Solutions. Chartis Clinical Quality Solutions is formerly known as the Greeley Company, and we provide to you as Chartis Clinical Quality Solutions the same readiness, response, and reliability programs that the Greeley Company has always provided throughout our 30 years of experience in the healthcare industry. We provide clinical quality expertise, patient safety, accreditation, regulatory readiness, infection prevention, specializing in acute hospital behavioral health, ambulatory surgery, many of the healthcare environments that we're all very familiar with. Today, particularly, we're going to be looking into one of the things that we do very well, which is emergency department and EMTALA regulations. But I also want to point out to you that the Greeley Company, now known as Chartis Clinical Quality Solutions, has the high reliability care solutions component, which you see everything over here on the right side of your screen. We also do medical staff services optimization, and that would include our peer review, credentialing, privileging, bylaws, rules and regulations arm. And we also have our education solutions, which are our national presentations, live in-person presentations. We're having one actually in Scottsdale, Arizona in October. That'll focus on medical staff leadership, institution, peer review, credentialing sessions, and so forth. And we have another one of those in December in Carlsbad, California. And then we also have our Chartis Workforce Solutions component, which is our interim staffing. We staff interim staffing for hospitals, other healthcare organizations, all the way from the CEO of an organization, infection preventionists, medical staff, office specialists, and so forth. So that's previously the Greeley Company, now Chartis Clinical Quality Solutions. Today's objectives for our EMTALA webinar are to really look at the challenges that have come to light during the pandemic that are facing our emergency departments, shortages in staffing, and what that's doing in terms of how we're receiving and taking care of patients, excuse me, and the increase of patients that are coming to our emergency departments for care with psychiatric conditions. We're going to talk about the strategies to sort of mitigate some of those challenges, and then successfully identifying approaches for coping with those long waits that we're having in the emergency department, both on the front end and then as inpatients are boarded in the ED, waiting for inpatient beds. Always been a problem with hospitals, just exacerbated by the pandemic. And then we really want to hit the crux of EMTALA. We want to clarify, what does it mean to stabilize or resolve an emergency medical condition, right? Stabilize the patient or resolve that emergency medical condition. And then recognize the important differences between lateral and higher level of care transfers. So as we talk about this in your chat, you're going to notice that we have the slide presentation in PDF format. That's going to show up several times throughout this presentation, only because as new individuals join, they might not be able to access the PDF that was posted previously. So you will be seeing that PDF if you joined from the beginning. Posted several times, same PDF of the slides, nothing different about it. You just need to download it once, even if you see it several times. So I want to just introduce myself. I'm Lisa Eddy, a registered nurse with critical care background and then into nursing leadership, hospital operations over in the C-suite side on into quality compliance and that avenue of healthcare. Registered nurse, and I am the Vice President of Clinical Compliance and High Reliability and moderating today. And I'll also be jumping in with some points of view with things. And then I'd like to tell you that we were pleased to have Bud Pate, our Vice President here at Chartis Clinical Quality Solutions of Content and Learning. And I'll let Bud's been with Greeley for over 17 years, has a background in deep background in CMS and accreditation compliance. How you doing, Bud?
Excuse me, I was on mute. Great, Lisa. Thanks. Great to be here today.
Thanks. And then we have Jesse Neal. He's our friend and collaborator from Waller Law. Jesse's from Nashville, but Waller Law is a nationally recognized law firm that deals with a lot of these issues related to compliance and EMTALA and so forth. So, Jesse, good to see you.
Thank you, Lisa. Thanks for having me. Always great to be here.
Thank you. So our agenda for today, we're going to be having Bud and Jesse weigh in on the high-level overview of EMTALA requirements, and then we'll all talk about the impact of the pandemic on the EMTALA challenges and some of the strategies for mitigation, what we've seen the pandemic do to our emergency departments and how we respond in EMTALA. And then we'll have a discussions and questions component where we'll address some of the high priority issues that are hitting our EDs today. So moving on with the agenda, starting with the high level overview of EMTALA requirements, Bud and Jesse, I'll turn it over to you.
Thanks, Lisa. This is Bud. I'll start off. I'll lead, and then Jesse will follow in and say, hey, it's really great to see everybody here. We have a great turnout today, and I see some I was going to say old friends, but they're not old at all. They're just previous friends. Let me put it that way. So it's good to see all of our friends in the audience. So welcome, guys. Now, I just want to focus this. We're not going to go through these questions right now, but this is what we're going to end up with at the end. Jesse and I are going to walk you through EMTALA fairly quickly. And so now if you have specific questions, you can put them in the chat or you raise your hands. Lisa will be helping us answer those questions as we go along or at the end. But we just wanted to let you know you should be thinking about, gee, what does this mean for my waiting room? What does this mean for the current crowding situation? What does this mean for how we have practitioners, how we use telemedicine, all those things. So the walkthrough of EMTALA is sort of a precursor to those discussions, and I just wanted you to know that. So as we walk through EMTALA, we just wanted you to know, you probably know this, but the most common cause of CMS termination actions is in fact EMTALA. For accredited hospitals. And the conditions of participation, where you have condition level findings, whether it's patients' rights, physical environment, infection control, those sorts of things, suicides, those are run behind EMTALA, which is the most frequent cause of CMS pain for accredited hospitals. And just to add to this, CMS was somewhat disappointed in the level of enforcement activity by the state survey agencies during the pandemic in particular. And so about a year ago, they sent this missive out to everybody to say, hey, don't forget your obligations, especially with respect to labor for our beneficiaries out there across the country. Now, before the pandemic, there were about, decreasing number, but right around 320 EMTALA investigations every year, according to CMS. And about 60% of those actually resulted in a threat of termination action. The people weren't actually terminated, but they had to correct things either within 23 days or 90 days, depending on the severity of the issue. And about 30 of these, or 15% of the overall number of complaints, were actually resulted in fines of the hospital or the practitioners involved, or both, of up to $106,000 for the hospital or $50,000 per violation for the practitioner. And then we don't have any data, but the EMTALA is a cause of civil action. And so we don't have any information about how frequently that is. So it's a hot topic. It's been a hot topic for decades, and it continues to be there. So the first thing we're going to talk about is the trigger for EMTALA. There's a lot of details that we'll get into later on, but what really starts the EMTALA ball rolling? And there are three triggers. The first trigger here is the person who comes to anywhere on your property and hospital property, including outpatient or ambulatory care locations in remote locations and is requesting emergency care or apparently suffering, they're clutching their chest and falling to the ground, or they appear to be in labor. That is one of the triggers. And the second most trigger that we want to get into, there's a second level of vulnerability or obligation, you can say, and that's when a person comes not just to the campus, but to what they call a dedicated emergency department. And of course, that would be, if you happen to have an ED, that would be an ED, but it's not necessarily something labeled an emergency department. It's if they come to, so for example, a labor and delivery, which would be triage area of labor and delivery, is typically considered a dedicated emergency department. And some other urgent care locations might also be considered, it depends, emergency department. And when they come to one of the locations, they can really, they don't have to say they're in an emergency. They don't have to be falling to the ground. They need to just be requesting care for any medical or surgical condition, with a few exceptions, but any medical or surgical condition. So Lisa, you had some thoughts on that?
I just want you, Bud, and Jesse, too, to weigh in on the freestanding psychiatric facility that has an intake area. Sometimes we see freestanding psychiatric hospitals receive some EMTALA violations because of something that happened in that intake area. So can you just elaborate on that particular situation, Bud?
Generally speaking, that would be considered a dedicated emergency department, and these rules would apply.
Right.
And I agree. And a couple of the hot topics in that area are maintaining the patient in the ED, de-escalation techniques, training prior to the visit, a plan of approach and escalation as needed with the staff and the nurses and the physicians, and having a protocol in place if they attempt to leave the location. It's not enough just to have them sign a form. And so those are some of the common issues I see in that context.
Yeah, good. So now, as we go through this, there's going to be some case studies that we show, and this is the first of them, but there are several case studies through our presentation, and these are all verbatim quotes from the Office of Inspector General of the Department of Health and Human Services. And this is where they do public notice of sanctions or monetary fines that are levied against different organizations. That's the source of these. So our first thing here is that a person came to this dedicated emergency department, was very belligerent. This happens all the time. And he was so belligerent that security ended up asking him to leave, or the nursing staff did. But he collapsed on the way out the door, but the security guard, not daunted, wheeled the patient off the property where he was left on the ground. And he ultimately died of his medical condition. This was the subject of a fine, I think, for obvious reasons. The same hospital had a separate patient, another belligerent patient, who was escorted out of the ED by security. And the patient's girlfriend subsequently took the patient out of the waiting room and went around to the ambulance bay, where the security guard just said, "No, you have to leave." And of course, the patient ended up having a very serious condition, and before the girlfriend could get the patient to the next venue, next hospital, he passed away. And here's another case study of where this trigger is really involved. The 79-year-old woman is a car accident and really should have been routed probably to a trauma center, but they did arrive at the ED, and instead of doing a medical screening, they just told the driver, just take the patient on to the trauma center, where without doing a medical screening, and during the transport, the patient died during the transport. And these were all subject to fines for, I think that's fairly obvious. Any comments on that, Jesse, Lisa?
Well, those are pretty straightforward.
Yeah. And if you have questions, oh, by the way, I didn't cover this. If you do have questions, there's a Q&A part. So please feel free, please participate in the Q&A. And we will pause at the end too, time permitting. There's a third trigger, though, that doesn't have anything to do with somebody who's appearing on your campus. This third trigger has to do with a request from another hospital within the United States or the territories for an unstable patient. Says, we can't stabilize this patient. We need as long as you have the capability and capacity of providing the stabilizing care, we need to transfer this patient to you. There's an EMTALA obligation, in fact, to accept that patient. And that's the third trigger. And there's a couple of case studies here that really, I think, bring this to life. There was this higher level of care transport, and we'll talk about lateral versus higher level of care transports in a little bit. But this was definitely a higher level of care transport of a woman, and the operator refused to accept it because they didn't accept Louisiana residents, and which is, of course, not at all allowed. And so they were fined for that, obviously. And here's another one where the patient was in the U.S. Virgin Islands with an aortic dissection. And the place that they needed to transfer, and they, of course, didn't have the capabilities of doing that sort of vascular surgery in the Virgin Islands. And so they needed to transfer the patient, but they refused to accept the patient without a guarantee of payment. This happened a couple of days. And a few hours later, of course, the patient passed away. And this is just an egregious violation of the letter of EMTALA.
One item,
comments? Yeah.
One item I would note too, just practically speaking, it's not uncommon for me to get a call from a hospital that believes that they became aware of an incident at another hospital, unaffiliated hospital, that imposes an obligation on them to report them to CMS. And it frankly is rare that they initiate a report without first engaging with the other hospital, one as a fact finding to determine whether there was anything missed in translation. Was there in fact a violation that triggers, it's reasonably likely to trigger that reporting obligation. And in my experience, because to a degree we all live in glass houses, you typically allow the other hospital, unless it's just a repeat offense or there's other unusual dynamics at play, allow them to self-report. And with that self-report, they should, if they call me, and I've advised them on this, it shouldn't just let them know that these are the facts. It should outline the root cause analysis that was completed, the plan of correction that they have adopted, the status of that, and everything short of inviting them to survey you probably puts you in the best footing when they do arrive. And when that report is submitted, the other hospital is still not off the hook. They need to submit their side of the story, and they need to submit it to the regional office. But you do that after the other hospital has submitted theirs, and it makes for a much more comfortable dynamic and productive dynamic too. So a little color and experience there.
Thanks, Jesse. Yeah, that's very important. I see Stephanie Rodriguez has a question that we could probably answer.
Yeah, I was just going to pop in there. I think we have enough time to answer this now. And it's a great question, So if a patient shows up at a standalone freestanding psych hospital because the patient has suicidal ideation or other emotional behavioral health complaints, can that particular freestanding psychiatric hospital refuse to actually accept the patient, see the patient, stating that there needs to be medical clearance before they can accept the patient? So Jesse and Bud?
Yeah, right. Psych hospitals, generally speaking, well, the simple answer is no. You would need to stabilize the patient. So if they're suicidal, you really have an obligation to do whatever you can to stabilize. Now, if they're having a medical complaint, and that's where they're there, you may actually need to rescue the patient, if they're having a heart attack or something, and then you can call 911 or transfer them. but you cannot, if somebody presents at your medical center, you need to stabilize them before you get the medical clearance on them. You agree with that, Jesse?
I do agree with that. To the extent that it's within the scope of practice of the professionals at the hospital, and they typically address any portion of even multiple emergency medical conditions, it's not uncommon at all to have a behavioral psychiatric issue and also a medical issue, contusion. And there are certain levels of basic care, CPR, that there's expected to know and to deploy on that medical side. And to the extent that you're able to address and stabilize the psychiatric condition, and once you've reached a level that it is either stable or unstable, and there's higher level of care that's needed either on a medical or psych, then at that point you would initiate an appropriate transfer. But if there's 3 or 4 or 5 things that are discrete emergency medical conditions, and you can do one of them or 2 of them or 3 of them, you need to do 1 or 2 or 3 of them. So you're on the hook for what you're able to do, and you need to be able to do it.
So let me move on here a little bit. I see we have Christine. We'll get to your question here in a second. So the one thing we did want to bring out, though, that you probably already know, but in case you don't, once a patient is admitted, not placed on observation status, but actually admitted to the hospital, then EMTALA no longer applies. It doesn't mean that other regulations or pre-existing obligations that you might have as a medical center don't apply, but EMTALA itself does not apply to inpatients requesting a transfer for services to other inpatient status. Lisa, have you had a chance to look at Christine's question? Do we want to do that now?
Yeah, sure. I think we do have time to do that. And so Christine is asking, if you have a patient who arrives in the emergency department and the nurse does the triage and determines that the patient does not have an emergency, they call the physician on call and they request the patient be sent to the clinic. Is this appropriate?
Well, let's defer that a little bit as to who can actually do the medical screening. Triage is not the same as medical screening. So somebody that you determine is what they call a qualified medical person can say, yeah, this person has a condition, the emergency phase has been resolved, but we do need them to be seen, so send them over to my office. That certainly is. So we'll talk about that a little bit more detail, but triage is not medical screening. But that's not to say that you may not have some sort of system between nursing and the medical staff to do that. So we'll talk about that just here in a second, a little bit more fully. So we talked a little bit about the triggers, and now we're getting into questions about, well, what happens after it's triggered, and we're going to get into more detail and probably answer some of the questions before they arise. So what if the patient comes to an ambulatory care center that doesn't, that's associated with a hospital, hospital-sponsored ambulatory care, or a freestanding hospital that just doesn't have an emergency capability? It just and some hospitals just don't have walk-in emergency services. What do you have to do? I mean, you have to do nothing? No, EMTALA would still apply to that person. You don't have a dedicated emergency department. That person who clutches their chest in your lobby and falls to the ground, you do have the obligation to do rescue usually, and that might be CPR. You may have an AED, that kind of thing. And generally speaking, if it's off-site of the main hospital campus, off-site of a campus where there's an ED, you're probably going to want to call 911 so that they can get them to the nearest thing. And you do have to keep a record of that patient. But the more common EMTALA obligations, the more complex, are for those places that do have a dedicated emergency department. And we're going to go into detail on stabilization, medical screening, and transfer. But people get, it's dedicated emergency department. You need a sign and you need a log. The log is usually, and people get all hung up on where to put the signs and not put the signs. It's a minor issue, but that's where now we're going to get into much more detail, though. Signs and logs notwithstanding, we're going to get much more detail about medical screening, stabilization, and unstable transfers.
Hey, Bud, I'm just going to point out for our audience, we're getting some great questions. And I think what we're going to do is queue these up and answer those once we get through some more of the bulk of the slides, because I think some of these questions might be answered in detail as we go through the program. So we will get to your questions as time allows, and just keep them coming.
All righty. So this person shows up and you are obligated to give them a medical screening examination. What is that? Well, triage and a triage score, assuming you're using emergency severity index, ESI score, is part of medical screening, but it is not the conclusion of medical screening. Triage is meant to determine the order of care. Now, you may have a practitioner who's on there, non-physician practitioner, or extended role nurse, or someone else who's got special training, and they may actually be able to determine, just based on their view, this patient definitely is a treat and treat. They're an ESI 4 or 5. We're going to go ahead and treat them, or we're going to just give them advice. And, that might be the conclusion of your medical screening examination. But the ESI 3s and 2s, definitely, then the more acutely ill patients are probably going to be seen by an emergency department practitioner. But just that one examination is not the medical screening examination. It's all of these things. And it now includes testing. And if the emergency medicine practitioner really needs a second opinion, it might be over the phone or in-person consultation. And obviously, consultation in person is usually part of the stabilization part, but it could even be considered part of the medical screening. Now, the question that was asked, can a nurse be considered a qualified medical person? There are examples across the country where a triage nurse can be considered as a qualified medical person. We have never seen that model work ever for a general patient. Now there's an exception to that, and that is a nurse working in labor and delivery who is a trained labor and delivery nurse and who's working in consultation with an obstetrician or nurse midwife who is available for them, and the nurse reports on their the patient's history a little bit, is their first baby, second, third, whatever, and what is their frequency of contractions, it's how dilated are they, and then they can work with that other person to complete the medical screening examination.
A couple of items I wanted to touch on too, and it'll be an ongoing reference point, I think, for the group. When I'm having discussions with either a surveyor or regional office or an enforcement official in OIG, there's a couple of different reference points that they almost lead with. I mean, they look at the facts of the encounter to see whether the medical screening exam was reasonably designed on clinical grounds to identify the issue, and if stabilization was reasonable efforts. But they really look at a couple different factors. Even though it's not a national malpractice statute, they want to know what the local standard of care is with regard to this screening and the stabilization. So regardless of what the case law says, it always says it's not a national malpractice statute. They want to know what it is and whether you satisfy that standard. And then two, and I thought this was very interesting when I first started handling these cases, they want to know if the care, both the screening and the stabilization for this patient, was similar, identical, comparable to what is given to another patient, a different patient who presents with similar condition symptoms. It's almost a touchstone for them that if one way is the standard approach, the typical approach, and in a given incident there's a different approach, it's almost per se a deviation from what is expected from the government's perspective on EMTALA, both in terms of both screening and stabilization. So having a protocol, training your folks on it, and executing on it in a consistent way with consistent presentations is surprisingly important. It's surprising to me anyway, surprisingly important with the surveyor. And if the survey doesn't go as well as you'd hoped with an enforcement official, it really is a top tier question that they have.
Thanks, Jesse.
Thank you, Jesse. I do want to pop in here, Bud, just to answer a general question. This session is being recorded, and we'll figure out how to get you the information in a recorded venue at some point at the
it'll be available for streaming on our website in a few days, and we'll let everybody know who's here when it is available for streaming so that you can look at it or have others look at it. As you will. So just to conclude the thoughts on this slide. So, this is very technical, right? So we've got an attorney and a bureaucrat like me, and you got Lisa, and we're all here. I've been dealing with this for decades, for maybe 30 years, ever since I was with the state agency when EMTALA came across the transom. So that's been decades. So you're not going to have this sort of understanding at the clinical level. So the easiest way to explain people, when is medical screening done? It's when you know what you're going to do with the patient. Are you going to transfer them? Are you going to admit them? Are you going to discharge them and have them get care later on? Once you concluded that, and based on an examination, not only, and Jesse made this point the other day, if they're in there for a psych complaint, remember, they also have a medical component to them. So you also have to examine not only the presenting complaint, but other things. If they come in and they're complaining of back pain, but they're having a blood pressure crisis, then you need to look at the back pain and the blood pressure, not just the one thing. But once you've looked at those things and you've determined, the tests are back, this is what I'm going to do, I'm going to admit them, I'm going to serve them, that's when medical screening is over, in our view. That's how you explain it to clinical people. So here's a couple more case studies. So a patient came in at about 7:30 in the morning, chest pain, vomiting, diarrhea, the typical cardiac syndrome. They put in the waiting room. The spouse is repeatedly asking for assistance, and the patient was never reassessed. And after about 4 hours, they left and went to another hospital where the patient had a cabbage. And so this is an example where somebody here is with obvious cardiac kind of symptoms, and it hasn't been ruled out by anybody. In other words, people do come in with chest pain, you do an EKG, somebody looks at it, you rule it out. But if you're not assessing or reassessing that patient, then you need to, they would be an ESI too, so they need to be moving forward. And they left, and then they were, so this was a subject of a fine, which is only about 15% of the cases actually result in fining, but this would be one of them. And so this brings up, well, what about all those patients who leave? We have people who come in with chest pain who leave all the time. What do we do with them? Well, the first thing I think we want you to do is look at your overall rate. Now, obviously, you want to look at individual cases that are serious, so that if somebody comes in and they're an ESI2, in other words, emergent, and you need to see them right away, and you don't see them, and they leave, that person, you probably want to figure out what's going on with them. But that notwithstanding, you still have an overall rate. And so let me take a minute to explain what it is we suggest you look at. We suggest you look at your overall left before the conclusion of care, not just left without being seen or elopements or AMAs, but you look at that aggregate result. Why do I say that? Because over the last several years, we've been trying to measure this front end, and people define these different stages differently. So if you will look at everything all combined, everybody who leaves before they're discharged or admitted, or transferred. Everybody as a whole, if your rate is lower than 2%, which I don't think you'll find anymore, but if you're golden, I wouldn't worry about that other than the occasional event that happens. If you're above 4%, I think you're at high risk, and most people nowadays are at high risk. Left before triage, there really shouldn't be hardly anybody. If people are leaving before triage, you need to look at your triage process. They're left with that being seen rate. You can usually get that down. I mean, we were able to get that down when I worked for Kaiser for 15 years. Throughout Kaiser, we got it to less than 1%, which was amazing. I'm not sure how long it stayed there. But that's, that's sort of a temperature check that you can do to see whether should I be worried or not? And of course, you would always be worried, but if you're over 4%, especially if it's 7% or higher, the higher your level of that being seen rate, the more, the worse you are. Plus, we want you to have a safety net there. We really suggest that any ESI2 that's an emergent patient who leaves before the conclusion of care, you probably need to find out what happened to that patient. You need to give that over to somebody who can do a follow-up and say, hi, Bud Pate, I see you were in the other day. We thought you were severely ill, but you left before we could complete. Are you okay? Did you get care? What happened? And then if it turns out that there's a problem, you can look at the regulatory mitigation. But of course, job one is the clinical care of that patient. And so we really suggest that. You may also want to do that for some ESI3s, probably not all of them, but some of them. Thoughts, Lisa, Jesse?
I agree. A well-developed protocol, particularly in the behavioral health realm, it needs to be taking into account the local resources. Rural hospital, you've got an ongoing working relationship with law enforcement or other dispatcher. And if a behavioral health patient presents and leaves before proper stabilization, discharge, you really need to involve law enforcement and follow a developed protocol, a search on campus. That's an example of one. And there are other categories of patients, depending on their acuity and presentation, that warrants, I think, a different protocol. But from a legal perspective and risk management perspective, you don't always have to be right. Having a reasonable policy that's set in advance, that has a reasonable training regimen around it, and you do your best in good faith to execute on it, that takes out the lion's share, in my experience, of the big catastrophic legal issues that come about. So think about buckets that you can put patients in. Think about clinical approaches that can be somewhat standardized. Boiling those down to a training approach really, I think, keeps patients safe and keeps the hospital, from a legal perspective, safe as well.
So
Great
I just want to pop in there and tell you, I think that's from some of the adverse actions that we get involved in with EMTALA and the federal requirements. That's key. You just said something very, very important, is in a very busy ED, if you don't have a policy that sort of outlines the practice of what the nurse should follow if that patient leaves before the continuation of care, particularly in the psychiatric behavioral health arena, that's critical to be able to follow up on that patient and prevent harm to that patient, that because of the nature of what they're accessing care for to begin with, emotional behavioral disorder, it's not improbable that they would leave even in a highly suicidal state. So to be able to protect them and have a pathway for staff to follow to do that is, I think, extremely important.
I agree.
Thank you, guys. So just a couple case studies and there are plenty more where this came from. So if you want some more case studies or you have a scenario, you can contact us. But this hospital had a policy that anybody with a blood alcohol level over 100 just went to jail. But of course, that's not sufficient. You need to do a medical screening and treat whatever's going on. So here we have somebody with a suicide attempt by overdose who happened to have a blood alcohol level of 422, very high. And instead of doing the medical screening and stabilization, they just sent them to jail. And there's another one with attempted suicide, and because of the blood alcohol level, they were sent to jail. You could see that's very obviously an EMTALA violation there. I think if anybody doesn't see that. And then here's another one where a homeless patient came in and was by ambulance diagnosed with a contusion to the face and discharged. The patient refused to sign the discharge forms, and you do have these patients where they come and they refuse to live. But she was homeless and she refused to exit the premises. Now that's a problem, but this solution was not the right one, because she was then escorted by the security officer off of the hospital's property, wearing only a gown and socks, which might be okay in Miami, but this was a 30-degree. It was 30 degrees outside, and she was found the following day by a bystander who called 911. And, this is obviously not the right solution as to how to get a homeless person who's sheltering from the cold and who wants to stay in your waiting room or in the main ED. Here's another case study where a patient with who had a kidney transplant, end-stage renal disease here, was complaining of shortness of breath. And they said, well, you really need to be dialyzed here. Go to the outpatient dialysis service. And of course, she did go to the dialysis service, but died because she was in acute pulmonary edema. And she died over there. This would have been something that the hospital should have provided directly without transporting them because of her other, it wasn't just the dialyzing that needed to be done. She needed to be treated for other things. So I think clinically we can all see that. Here's another one. 25-week pregnant woman, premature, obviously. She went to the hospital saying, I think I'm in labor. And going into labor, the hospital, without providing a vaginal exam or determining whether in fact she was in labor, the physician wanted to have her transferred to higher level care. Fair enough. I mean, at 25 weeks, you need to have that baby. If the baby has a chance of survival, they need to be at a tertiary care hospital. But because it was going to be 45 minutes for the ambulance to get there, the physician just says, well, why don't you just drive to the next place, which is not ever a solution, as Jesse will tell you. And of course, she delivered the baby in the car, which of course didn't have a chance. And so
I'll highlight that. I've had an opportunity on a couple of occasions to do pretty large scale education in collaboration with government enforcement officials. And there's nowhere in the regulations that say a private vehicle can never be meet the standard of an appropriate mode of transportation. Examples come to mind where if there's a patient indicating some relatively mild self-harm questions and she's with family, and the transport would be a short duration, and taking an ambulance would be very disruptive. There's a tendency there to say, well, this is in this case worth it. This in this case is the best. The government's position, right or wrong, is that a private vehicle in any context can never be an appropriate mode of transfer. So if they're stable and are discharged, and then they're going to go see another provider in another location, robust documentation, because if it deteriorates on the way or at the other location, the facts are very difficult to overcome. And so it's important to keep that in mind. If there's any doubt at all that the patient will be okay, and if they aren't quite sure that they're stable for discharge, an ambulance transfer puts you in safe ground with the regulator, at least.
And just to reemphasize what Jesse said, that patient that's going to go by private car is being discharged. They're not being transferred, guys.
Right.
So you need the documentation has to support the fact that the emergency phase of that medical condition has been resolved. Okay. They still have the medical condition and they may need to be seen later on that day. But the emergency phase has passed. And it's often hard to argue that if you say, go to the next place right away by car. It's just very difficult to align those dots. But let's talk a little bit more about transfers. You know, not all transfers are covered by EMTALA. Not everybody leaving for another hospital out of your ED by ambulance is an EMTALA covered transfer. However, the difference is probably something that Jesse or Lisa or I could tell you, but we don't want, you know, so what we recommend is that you ask the clinician to determine one of three status for every transfer. Is to either deterioration is unlikely during the transport, or deterioration may in fact happen, but the risks of staying are greater than the risks of deterioration, or the patient requests transfers against medical advice. Those are really the only three options. And if the first option is there a deterioration unlikely during transport, you don't need to meet that bar to justify that the risks of transport are outweighed by the risks of staying, because for a lateral transfer, you're not going to be able to figure that. So, and Lisa's reminding me we only have about 10 minutes left, so I'm going to go through this a little bit. But I think that's an important thing. Now, it doesn't mean you don't need a transfer summary, but it's difficult to document that the risks of transfer are less than the risks of staying for somebody who's being transferred because they're out of network at your hospital and you want to get them to another one. But if you're going to do that, you really need good documentation that deterioration is unlikely. If you can't document that, and if there is a predictable, reasonable chance, not 100%, but reasonable chance that they'll deteriorate, then this entire EMTALA transfer protocol comes in place. You do have to, the physician not only has to say the risks are greater, of staying are greater, they have to sort of put a clinical note in there as well. Why are you transferring this person? Well, they need specialized care and we don't have it. Okay, what care and what's needed? That needs to be there so that you can justify that. And then, of course, the patient needs to consent to that. Or if they refuse to consent and stay, they need to know that they're putting their patient at risk by staying at the hospital. Yeah, that has to be accompanied by clinical records, and then that's the EMTALA transfer. Any more help or illumination on that point, Jesse or Lisa?
I'll just reiterate that it cannot be, the documentation is critical. It cannot be conclusory. The factors that are used when you're making a determination about the risks of transfer versus the risk of staying, they need to be detailed, itemized, and the rationale for the conclusion needs to be in the documentation. And that I understand is a tall order when you're in the heat of battle, trying to save and treat and interact with the patient and their family. But I've seen it time and time again where the government just does not believe that the documentation is sufficient to really show and demonstrate that EMTALA was satisfied. And in that sense, the burden is on the hospital. So keeping that in mind when you're making these documentation, it's a hospital issue and it's a personal, professional kind of risk management exercise that you're going through. So it's really important to focus on that determination and analysis. You can't document too much. I've never seen it happen.
Thanks, Jesse. So I'm going to give it back to Lisa, who's going to take us through the rest of our program. Thanks, Lisa.
Great. So thank you, Jesse and Bud. I'm going to blow through these next couple slides pretty quickly because I think these are just a couple of slides that talk about the Great Resignation, that 1 in 5 healthcare workers have left the field during the pandemic. I want to point out that 30% of nurses have left the profession during the pandemic, which that just is a cascading event cascading series of events that puts more and more and more pressure on the both inpatient side and the emergency department side. But if you go to I really have some good questions I want to get to. So if we take a look here, the safety related metrics, I think we all have seen this. If you've been in any of your committees or whatever, your the hacks are going up, your infections are going up because of the Great Resignation. But we don't literally have the staff, and hence the time, and hence our practices that we have put into place before the pandemic have been eroded because we don't have the staff and resources and supply chain, and on it goes, to sort of effectuate the positive care to patients that we'd like. ED overcrowding, the harmful effects, there's been numerous articles about that, both on the medical side and the behavioral health side. So we just want to point out that we know that because of the staffing shortages and the supply chain shortages and so on and so forth that the pandemic has brought forward, it is impacting our portal of entry, the ED department, as well as the inpatient side. So, but if you go to the next slide, I think it's some of our questions. But before we get into these, there's some great questions I just think we have time to answer very quickly. And one is from Stacy. If a patient is an inpatient, medically cleared, and needs to be transferred to a freestanding, now mind you, the question is, if a patient is an inpatient, right? They've been medically cleared, needs to be transferred to a freestanding psych facility, does EMTALA apply for the accepting freestanding psych facility?
No.
Okay. Next.
I mean, so I mean, I know that's a brief question. But the psych facility doesn't have the EMTALA obligation to accept.
Okay, another question here, and I think we all know the answer, but it's a unique situation that we've dealt with. I know I've had this situation happen. In what's the question is, what is the recommendation if a visitor becomes unresponsive in your facility? They're taken to the ED for evaluation. They wake up, they refuse care before it's ruled out that there is or is not an emergency medical condition. Is the patient, if they're awake and conscious, can they leave EMA? What is they have capacity to make their own.
Yeah, they have the right to leave, but I would document the heck out of that because it's a vulnerable situation. It's like any other person who leaves before the conclusion of care. But unless they're a danger to self or others, according to state law, or gravely disabled, and again, that's a state law issue, right. Those people you have an obligation to essentially keep from leaving and protect. But assuming that this person doesn't fall into that category, that they do have the right to leave.
So one item I would note there, my presentation with the government official was entitled "Great Expectations," because so much of what they expect a hospital to do is not in the black letter law. But the government, I think, in this context, would expect the hospital to do everything that state law allowed them to do without crossing into illegality to keep patients there. There should be a process and a protocol developed. They expect that the bottom line is you've got a process to get patients who need care to that care. That's it. And so a one-off where it's well documented, maybe they sign it themselves and acknowledge that they've been given the opportunity to get additional care. It's recommended additional care. They refuse it. They deny it. If that happens regularly, the surveyor is going to want to know and understand why. What's the process? What's the staffing model? What is the training that's been involved in this? What they're going to probe, and they expect if it's an issue, if it happens more than just on a one-off basis, that there's an underlying process issue that really needs to be addressed and changed, and that's going to be their expectation, and that's what your plan of correction is going to have to be if they come survey it and believe that even if it's not an immediate jeopardy to the patients, that if it's happening semi-regularly, it won't be uncommon at all for them to flag it as a deficiency.
Thank you, Jesse. I want to point something out because we've got about 6 minutes left, but I'm on this slide here. These are things that the regulators are beginning to catch up. And so we're asking you to look at your own practice and ask yourself some questions. But I want to point out something that is plagued our clients in finding after finding after finding in different hospitals. And that is, what is your policy on taking vital signs, which means really assessing that patient that's an ESI 3, even an ESI 2 that moves to a 3 or whatever, because that can happen in the process of the patient's care. We are finding hospitals, because the EDs are so busy. They have an ESI 3 patient that is triaged, and they're sent back out to the waiting room. They're triaged as a 3. They're back out in the waiting room. And you've got a policy that says you're going to do vital signs and assess that patient every 2 hours, 4 hours, 3 hours, whatever it happens to be. First question I would ask is for an ESI 3, there's kind of little different levels for ESI 3. So you have to use some critical thinking. But what does your policy say? And ask yourself, is that policy reasonable? So for an ESI level 3 patient, vitals every 3 hours, 4 hours, and that's eyes on the patient and assessment. Is that practical? Is it reasonable? And if it is, are you doing it? That's where we see people getting into trouble. They have patients that are ESI 3s found dead in the waiting room. I mean, after 6-7 hours, nobody had a chance to get to them. They're sitting they're not in the direct line of back in the ED. Nobody has their eyes on them, literally, on an ongoing basis. And so we see this happening time and time again. So it's a cautionary tale.
And ESI 3s, I was saying, we see ESI 2s who wait 13 hours for care. So if you've got an ESI 2, the expectation is 15 to 30 minutes by ENA. Okay. And so within that 15, 30 minutes doesn't mean you have to get them a bed. It means you have to be having someone with eyes on it with a clinical setting. Can this patient wait? And if they can wait, let's put them in a place where we can observe them directly. The ESI 2s are really high risk.
That they're very, very important. ESI 2s really, you really need to follow the ENA if you're establishing policy. But Jesse, your thoughts on that?
I agree. And so much of this in my experience recently during the pandemic, particularly finding people who are qualified to make these determinations and having a fully staffed ED is getting more and more rare. And to me, that's an underlying issue. I think that documenting the clinical basis for determining a protocol, it doesn't have to be a white paper, but also having a policy that's not static. If you find that 4 hours or this level and that issue are not addressing and getting patients to where they need to be, it has to be kind of a living, breathing protocol, and to show that it is proactive and that they're learning from what they are doing in the ED, for example. Again, this is talking about legal risk as opposed to clinical best practice or local standard of care. But in terms of mitigating legal risk, those are the boxes that you'll want to check when you're developing an approach.
Thanks, Jesse. Go ahead, bud.
Yeah. So I just want to emphasize, look, this is something we deal with every day. As Jesse said, it's getting more and more. So we would be surprised if anybody on this phone doesn't have risks that they're trying to manage. But the solution is going to be individual based. And so feel free to contact us, ask us questions. We don't need any, just say, here's my situation. You have every situation is going to have a slightly different solution to it. So I just wanted to.
Thank you, Bud. I do want to point there's a question that's very pertinent that I want to get to before we close out. And then there's Jennifer's asking, what's an ESI level 2? I'm not going to get into the severity index screening, but an ESI level 2 is a patient that's extremely ill. ESI level 1 is they sort of come in coding. Then ESI level 2 is the risk of harm is extremely high, and the use of resources is extremely high. Think of a chest pain patient with, or somebody that's, gunshot wound that's not an ESI 1 per se. They're not coding, but they're so extremely, extremely ill as a 2, just generic explanation. We have a question here from Amy that I hear all the time, and I'd like Bud and Jesse to respond to it. Does the receiving ED required to accept a stable patient? I heard stable patient, because the transferring ED's hospital is on transfer closure diversion. So you've got a stable patient that needs to be transferred the hospital's ED is on transfer, closure, or diversion.
Well, I mean, I need a little bit more detail on that, but generally speaking, if you don't have the capability of continuing to care for that patient, then even if it's a sort of standard thing, a truck just drove through my ED, I can't really provide even basic stabilization care for the patient. I need that. Then they would have an obligation. But if you're just, so I'm not, I don't know what else I would be able to say on that. I can't imagine, once they're stable and you don't, so technically speaking, once they're stable, the receiving hospital says, well, what, do you have the capability of taking care of this? Well, are they stable? What do they need? Well, they just need regular care. Can you give it, so they don't really have that obligation. But I think that's something that you would need to escalate at the receiving hospital before you decline to any transfer from an ED. So if I'm the receiving hospital who's declining that transfer, I would be very careful to make sure that you understand the situation and the nature of the request before you make that decision. So actually a complex question.
Thank you, Bud. One more.
I would just say I agree. And one other item to look at in that context, if you're on the receiving hospital, you're on the side of taking the patient, you engage between CEOs or CMOs with that sending hospital, and you make a determination whether you've got a duty to report them. Depending on the facts that led up to it, there could be an issue there that needs to be worked through, and that's a standalone violation. You don't see it often, but failing to report when they really did have the capability and capacity from the government's perspective, they never see someone who doesn't have capability and capacity. They're very, very skeptical. So I think that's an item to keep on the list too.
Here's another issue, and we'll conclude with this. It's one last question, but it happens all the time in almost any ED, and it is, we frequently have patients that are evaluated and discharged from the ED that immediately return. These patients can return multiple times. I see this so much, multiple times, sometimes within seconds or a few minutes of being discharged. The question is, do we have to do an MSE each time? Do you have any recommendations on how our organization can address these situations? And we know many times these are homeless patients but
we run into this a lot, guys. And so probably need an offline conversation with this. By the way, before we answer this, I don't know that we have this in the slides, but it's L. Eddy, Lisa Eddy still at Greeley.com. We're still using the Greeley address. So L.Eddy at Greeley.com, bpate also at Greeley.com. So bpate at Greeley.com. Jesse, we didn't have your email in this. Do you want to put your
Sure, JESSE.NEIL at wallerlaw.com.
That's WALLER law, right?
Right.
WALLER.
So we'd be happy to take this discussion offline for a fuller, but simple answer is yes, you do have an obligation to do medical screening if they're failing, if they are complaining of an emergency medical condition. Now you can rely on testing you did in the prior before, but every time they represent, you have to do that. But oftentimes these patients just refuse to leave. It's not that they're representing, but they refuse to leave. And there are approaches to do that. And whoever had that question, if you will send us an email, we'll set up some time. And this isn't just a curbside consult as to the various approaches to these situations that we found to be important.
All right, folks. Well, thank you very much. And as Bud said, this recording will be posted on our Chartis Clinical Quality Solutions website, likely under the high reliability compliance component. And we thank everyone for their participation today. And we appreciate you, Jesse, very much for joining us, our good colleague from Waller Law. And Bud, thank you very much. Thank you, everybody.
Thank you. It was a pleasure. Thank you.